Okay, welcome everyone, and thank you so much for taking the time to be here this evening. I am Dr. Jhanelle Gray, Department Chair and Program Leader of Thoracic Oncology at Moffitt Cancer Center. I am excited to introduce you to my colleagues in just a moment, and I'm confident that you will find value in the information that we will share with you tonight. Before we begin, please be advised, we can go to that next slide, please. The content is not intended to be medical advice, and the viewers should consult with their physicians should you have any questions. The viewers should not rely on the information contained in this presentation for immediate or urgent medical needs. Additionally, if you think you may have a medical emergency, please call your physician and go to the nearest emergency room or call 911 immediately. Never disregard professional medical advice or delay seeking care because of information contained in this presentation. All right, next slide, please. Again, we are so pleased to have you with us tonight. Our team is so proud to be part of Moffitt Cancer Center, the only National Cancer Institute designated comprehensive cancer center in the state of Florida. You know, one area of strength in particular is Moffitt's Thoracic Oncology program, which specializes in the diagnosis and treatment of thoracic malignancies, including lung cancer, thymomas, mesothelioma, Pancoast tumors, and other thoracic malignancies. Our team is multidisciplinary and includes surgeons, medical oncologists, radiologists, radiation oncologists, pathologists, and pulmonologists, who all specialize in treating those thoracic malignancies. Because of our exclusive focus on this particular range of cancers, we're able to provide each patient with an individualized treatment recommendation that gives the best possible diagnosis, not to mention the best possible quality of life. At Moffitt, we take our time to learn each patient, and over that time, we recognize that treating patients includes research at the bench to create new treatments. And then what we do is we transfer this right back to patient care. For patients with lung cancer, this means understanding the unique qualities of a patient's individualized cancer to really develop those personalized treatments. This is something that we really feel very strongly about here. Additionally, Moffitt runs a robust clinical trials program, giving our patients opportunities to receive the most advanced cutting-edge treatments that have not been made available elsewhere. Our thoracic program really focuses on these exciting breakthroughs, and we are working to capture and have captured the nation's attention. And throughout the evening, including starting with our first speaker, you will hear about this. We are leading the way in innovative treatments and approaches, as well as trial development. Before I introduce our speaker, I want to remind you that after we hear from our speakers, we will have the opportunity for you to have your questions answered by these experts. And we invite you to type your questions in the Q&A box at the bottom of your screen. Now, on to our presentation. I am very pleased to introduce Dr. Lary Robinson, who's been at Moffitt Cancer Center for more than 20 years. He specializes in thoracic surgical oncology, including the treatment of lung cancer, and also conducts clinical research. Today, he will be discussing several planned research projects for which he leads. Dr. Robinson?
Thank you, Jhanelle. I'm a thoracic surgical oncologist, which means I'm a thoracic surgeon who operates on people with early stage lung cancer. And that's been my focus. Could I have the next slide, please? I don't need to beat you over the head with the importance of lung cancer, but it is a severe problem in the United States and in the world. Over a quarter million people, almost a quarter million people in America get lung cancer just in 1 year. That's what's estimated for this year. 132,000 people will die of lung cancer in the United States. That's about 1 every 4 minutes. So it's an enormous problem. The problem why so many die of this is because only about 17% are found at a potentially curable stage. Fortunately, some innovations, which Dr. Creelan will talk about, show that we're making some progress in late stage disease, but still the ideal is to find disease at the early stage. Because around 1.5 million Americans are found every year to have a lung nodule. And the problem is, only probably 60% at most of these lung nodules are even followed up. And many of these may turn out to be cancers that eventually are found, but they're found in later disease. They're often discovered in acute care hospitals in various settings, but they don't get followed up. There's no surveillance scans, and there's a lot of nodules that fall between the cracks until they show up with very advanced disease. Can I have the next slide, please? 95% of these nodules are found incidentally, and as many as 2/3 don't even receive clinical follow-up after it's detected. The average time from a diagnosis until a nodule is evaluated maybe as long as 8 months. And then patients are sent for surveillance CT scans. The high-risk patients, as many as 17% might even have lung cancer. But the problem is that 35 or 38% of the biopsies that are done on nodules are benign. And those who end up with surgery of nodules that have no diagnosis, at least a quarter, as many as 1/3 of those may be benign nodules. So it'd be very important to try to figure out ways that we can diagnose the nodules short of an invasive way. Next slide, please. This is just an example of a patient I operate on. In fact, I saw her in clinic today as follow-up, just to show you how a nodule could be followed and missed for a long time. The far left-hand side, in 2018, this small nodule was found in her lung. You can see with the arrow. 2 years later, they got another CT scan, and the nodule was bigger. Waited another year, and it was bigger yet. They got a PET scan in the far right-hand side, which shows it was positive. So this enlarging nodule, essentially the only thing it could be was lung cancer. The problem is, many times people have unnecessary tests, including needle biopsies, which end up with complications. This particular patient had a needle biopsy or lung collapse. She got blood in her chest. She was in the hospital for a significant amount of time, a lot of complications. And then we went ahead and took out this small cancer. By the way, the needle biopsy didn't even show the diagnosis. So she was out of the hospital in 3 days. Next slide, please. This is another lady, 62-year-old, current smoker, found to have a nodule in 2019. A year later, the nodule was bigger. A year later than that, it was bigger yet, and it was positive on a PET scan, which indicates it's obviously, active. We went ahead and took this out, and unfortunately, by the time we took it out, one of the lymph nodes outside of the lung had cancer in it. So she went from stage 1, which is probably what it was in 2019, to stage 3A. So watching nodules, especially ones that are growing, is not a good idea, but it's done frequently for a number of reasons. Next slide, please. Management of indeterminate lung nodules, that is, ones without a diagnosis, require a great deal of organization. And a lot of pulmonologists and internists out in practice don't really have a reliable system. Patients tend to get lost for follow-up. Many physicians aren't even aware of the recommended guidelines. They'd rather not be responsible for following these patients because it may take a lot of follow-up scans, looking at the results. Many physicians also worry about medical legal concerns, that they'll get a scan, they won't see the result, and then the patient will show up later with an advanced cancer. Primary care physicians don't order the screening CT scans that they really should be. Only a little less than 4% of the eligible patients to get screening chest CT scans actually have them ordered. In fact, I was at my internist today. I asked them whether they ordered screening CT scans for them, and they kind of hesitated and say, well, they're a little hard to follow up, and we do if the patient asks for it. So it's something that it's not done very often, and it's the only reliable way to find early stage lung cancer. Next slide, please. So our plan is to go ahead and get a more organized approach. Now, currently, all of us thoracic surgeons, we see lung nodules all the time. What we'd like to do is reach out and make it more available with a lung nodule clinic, a clinic that's dedicated to evaluate patients who have lung nodules without a diagnosis and try to find more early stage cancer. We target patients who have no tissue diagnosis, have various sizes of nodules, various ages, smokers, non-smokers, and we'd offer a clinic visit within an initial 1 week of contact. And we'd follow up many of these patients, if they're just having a follow-up and don't need anything else except follow-up scans, they can even be done with virtual visits. The sources we get these from are a lot of the community pathologists, or excuse me, pulmonologists, oncologists, and internists, family practice physicians. They would like to really relinquish control of these patients with nodules, but don't really have a good place in which to do that. We would follow them along. New nodules also can occur after patients have had surgery, so we'd follow those along as well. And we'll get referrals for second opinions. Next slide, please. An organization of such a clinic, we would plan to follow all the major guidelines, would do some appropriate blood tests, and also counsel patients on diet and lifestyle changes. You'll also use what's commonly used, but not at least out in the community. The Mayo Clinic has a solitary pulmonary nodule malignancy risk calculator, which can really tell you whether or not a patient likely has a cancer based on a number of factors. We'd create an evaluation and treatment plan, and then do the appropriate biopsies if necessary, or referral for surgery. Where we will be using some proprietary software programs that really keep track of patients very well, more than you can do manually, so patients are not going to get lost in the cracks, and that's what happens commonly on the outside, and then provide feedback for the referring physicians. However, we'd ask all of the patients to continue regular follow-up with their personal physicians for their hypertension and everything else. All we would do is follow nodules as necessary or do the appropriate procedures for those patients. Next slide, please. Now, you can marry research with good clinical practice, and our plan is to do a very clinically oriented study in addition to the nodule clinic. And this would involve the use of biomarkers. Right now, we use our best judgment and all the other factors that we have to try to determine whether or not nodules are cancer. Well, we're looking at a number of biomarkers. These are biomarkers or any kind of substance, that's blood, urine, tissue, that will help measure whether or not a patient has a certain disease, cancer, and will predict the outcome or disease. So we're going to look at 3 time points that are important for patients who have cancer. The initial diagnosis, whether it's cancer or benign, risk stratification, because after you have surgery, not everyone's cured, even though the lymph nodes are negative. And we want to see who would likely benefit from adjuvant therapy after after surgery. And then look for long-term surveillance, all looking at biomarkers. Next slide, please. This is an example. You see a patient in clinic, big mass. You can see on the top one, which is a cancer. Top on the left-hand side, something that looks like a big cancer is positive on a PET scan. The second one's a smaller nodule, also positive on the PET scan. Which one's a cancer, or both? Next slide, please. Another one. We gave antibiotics to the first one because the patient did have some symptoms. Next slide. And again, as you can see, it completely resolved this whole large area, which looked like it might be a cancer with antibiotics. But you have to decide who to give those to. Next slide, please. The bottom, we took the operating room, and you can see, next slide, this one was a small stage 1 cancer. We had to do a number of things to try to figure that out, and we're going to use some biomarkers for that reason. Next slide. Next slide. After surgery, this is a common question. Could you go back one slide, please? I'll come out to see a patient, and after they've had surgery, and the common question, I've asked this many, many times, I've been asked, did you get it all, doc? And what I'll say is I took everything I could find. Unfortunately, what they hear is you're cured. The problem is it's not true for everyone, unfortunately. Next slide. This is an example. A gentleman I operated on about 2 months ago. 76-year-old, asymptomatic, had a large mass, PET positive, former smoker, took out his cancer, the lobectomy, and it showed there was a larger tumor, 2.9 centimeters, lymph nodes were negative. However, is he cured? No. Well, maybe. 66% chance he's going to be cured of this long term, but there's no evidence, just taking everyone as they come, that surgery, that giving adjuvant chemotherapy or other treatments is going to make a difference. Next slide. About 40,000 patients are diagnosed with lung cancer annually in the United States, early stage enough to have cancer surgery. However, about 20 to 50% of those patients will recur after surgery, even with lymph nodes negative. And the recurrence rate is related to distant spread of the tumor, cancer cells elsewhere out that we can't find with our fancy tools that we have. Next slide, please. As you can see, the recurrence comes usually within the first month. If you look at the first year on the far left-hand side. And the recurrences, most of them are distant metastasis, distant spread, goes to the liver, the brain, the bones, or someplace else. It'd be nice to find out the people who are at high risk for this occurring. Next slide, please. Our second part of our study that we're using is a special tissue-based biomarker, which uses a number of different kinds of genes, 14 different genes that can classify patients after surgery into high or intermediate risk or low risk of recurrence. Next slide, please. This we're going to use in this study. This is just an example, and I'll try to go through this very quickly. This study, they took 250 patients and prospectively who were node negative, had surgery, appeared to have a high chance of cure, had stage 1 to stage 2 disease. They did this test on them, which is essentially taking some of the tissue from the tumor itself. Of the high-risk patients, they offered chemotherapy to those patients. Some of the patients agreed to have it. About 40% of the patients did. The rest decided they didn't want chemotherapy. They followed those along. The low-risk patients also received no chemotherapy. And if you look on the far right-hand side, this is a 5-year free of disease recurrence. The green are the patients who were high risk and had chemotherapy. There were 97% of those patients were free of disease at 5 years. The low-risk patients who did not get chemotherapy were about the same, about 90%. The patients who did not have chemotherapy were considered high risk. They were down to a third of them had a recurrence. We'd like to get those curves all the way up at the top. So this we plan to use in this study on patients who have lung cancer and who've had surgery. So these are some of the innovative ways that we can use research to help in the immediate treatment of patients undergoing surgery or follow-up for early stage lung cancer. I'll stop at that point, and we'll have any questions at the end, we can answer them. Thank you.
Great. Thank you so much, Dr. Robinson. That was a wonderful presentation, really talking about the important and salient points regarding lung cancer screening and importance of speaking and meeting with your primary care physicians to see if you are eligible, and as well as talking about the role of early detection and risk stratification and what we can do to identify which nodules are going to be the ones that we more worry about versus the ones that we can follow or even treat with antibiotics. And then even if you do get diagnosed with lung cancer, how do we risk stratify? What is your risk of the cancer recurring? So really great presentation. We'll look forward to getting to those questions a little later, like you mentioned. Next, we are going to introduce you to a patient named Richard Stayskull, who is an active duty Green Beret. We thank him for his service. And unfortunately, he was diagnosed with lung cancer. He really does, though, have an amazing story to tell about his diagnosis and treatment. And please see this short video.
I think inherently as humans, we avoid the things that we can't control, and we like to shy away from them, and this one won't let you. Cancer's it's a faceless enemy that can't see. Started in the Marines. I went in the infantry. I got into the world of being a sniper very early on. Pretty much been doing that my whole career. Deployed, and then April 6th of 2004, I was shot. You train and plan for the best, and then once it happens, it's just controlled chaos from there, and you do the best you can to manage. It was around January of 2017. I was getting ready for dive school, for combat dive school, and before I knew it, I found myself just struggling with breathing. I just remember my chest felt heavy. Everything got worse to the point where I was now coughing a lot. Here and there was blood coming up.
Rich had gone in to see a civilian provider in the town that we live in. I remember Rich telling me the last question he had asked him was, "Are you coughing up blood?" Rich said yes. and Rich went in for a biopsy, and I remember it felt like an eternity while I was waiting. But he came in and he told me that he had cancer, told me that he thought it was stage 3. Okay, well, where's Rich? Does he know yet? And he said, no, he's still sedated. He's kind of waking up.
I remember my wife was crying and told me I had cancer, stage 3, lung cancer.
I think he was in shock. And I, of course, was crying again. And the nurses that walked in were crying with me. And that was a hard day. And then obviously having to go home and figure a way to tell our kids.
So at that point, Richard decided to enroll in a very high-risk, high-reward type of a trial using cell therapy. Cell therapy is when we grow immune cells or harvest immune cells from your body and train or activate them to fight the cancer. We did surgery on the neck tumor, removed most of it, and cultured immune cells from the tumor. These are trials which are often phase 1 trials, sometimes even first in human trials. We're doing something very novel to either change the DNA of the immune cell to grow large numbers, billions of immune cells, and tweak your immune system to be more active against the cancer. And he responded beautifully where any residual tumor basically went away. He doesn't back down from any challenge. He's willing to go for it. What makes us unique is that we're able to offer this breadth of trials and treatment strategies for patients. We've had patients who've had terminal diagnoses of stage 4 lung cancer and subsequently have had durable remissions.
They care. It's not just seeing a patient after patient after patient. It's investing the time and energy in getting to know your patient. And I feel like we get that from Moffitt.
You know, he's really a hero for our country. At the same time, he's also become a hero in a different way on a different battle line, which is a fight that he, of course, never signed up for. We're learning so much from patients like him and hoping to develop even stronger immune treatments in the future.
It's given me a unique perspective of how wonderful life is, how great my friends are, how awesome my family is, my kids. There's just so many people out there that still need help.
Really, thank you again, Dr. Creelan and Richard, for that very moving video. As you saw, Richard is a patient at Moffitt and is specifically a patient of Dr. Ben Creelan, who is an associate member in our Thoracic Oncology program. Richard is on a trial where he is a trial of what we call cellular therapy. It is really a major focal point of research here at Moffitt. And it is really some of the efforts that Dr. Creelan is leading to help move forward. We are really doing some exciting work in this area for lung cancer. As you saw, as you likely know, Moffitt has made a big imprint in this area, starting with TIL therapy for melanoma, helping with some of the biggest advances in this disease in 30 years. We also helped to bring CAR T therapy to clinical trials, and it is now ready and in the commercial arena for use for the treatment of blood diseases. And we now conduct more CAR T treatments per standard of care than any other center in the world, not just in the state of Florida, not just nationally, but in the world. What's new at Moffitt is that we are bringing cellular therapies to solid tumors, and we are also leading in this area, in particular with TIL therapy and the treatment of lung cancer. And with that, I'd like to introduce you to Dr. Ben Creelan to talk about cell therapy. Dr. Creelan is an associate member in our thoracic program. He focuses on translational and clinical research, specifically development of new immune therapies to treat lung cancer. His research is looking specifically at live cell therapy to fight lung cancer. And this means taking the patient's cells from their body, growing them, and then giving them back to the patient. And with that, I'll introduce you and transition to Dr. Creelan.
Thank you, Jhanelle, for the chance to really talk about this today with everyone. And thanks for tuning in. When I went into fellowship, I didn't realize how important the immune system was going to be for treating cancer. At the time, we'd had chemotherapy and targeted therapy, but the immune system was always something that we kind of just forgot about going through our medical school and fellowship and residency training. But now it's become such an important part of our daily lives as oncologists. So next slide. And I just want to echo also what Lary said earlier about screening CT scans, that at the end of the day, most of the lung cancers that we can truly definitively cure in clinic, a lot of them are the ones that we detect by screening CT scans. So if you have any friends or family members that would qualify for screening CT scans, smokers, former smokers, anyone with a modest history of smoking, please refer them to a screening CT scan if they haven't had that. Okay, so again, we went over that one of the big breakthroughs in the last 5 years or so is immune therapy using immune checkpoint inhibitors, Keytruda, Opdivo, Tecentriq. Yet all of these are essentially similar drugs made by different companies doing the same thing. And at the end of the day, only a subset of patients with lung cancer actually respond to Keytruda or Opdivo or Tecentriq. And if your cancer doesn't respond, which is the majority of patients at the end of the day, what do you do? And is there anything else that can be done in that situation? Well, that was the goal of our last trial that we did using cell therapy. We harvested a tumor from patients with stage 4 lung cancer. And what we do with those tumors is we morselize them, we cut them into tiny pieces, then we culture the immune cells, the T cells from that material in our cell therapy facility. And we grow that into an army of billions of T cells. And meanwhile, the patients, if they progress on the standard Opdivo, we infuse those T cells back in the patient. Now, one of the important components of this is that patients are required to have a pre-treatment chemotherapy session for 5 days to make space for those new T cells. And that does cause some low blood counts and can cause side effects because, hey, it's chemotherapy. But the important point is that you're getting this huge new infusion of cells that were large part more specific for the tumor. And our goal is to try to get your immune system to reject the tumor. So again, it's a pretty intense or involved process for a few weeks. And in fact, you're even in the hospital for a couple weeks during this treatment. And we also give interleukin-2 during the treatment to help boost those cells or help them persist or engraft in your body, stick around essentially. But that also has side effects. It causes some flu-like symptoms. But again, it's an intensive couple weeks, and then patients get restaged. Next slide. So this is an example of a patient who did go through the TIL treatment. I was very surprised when this patient so she responded initially to the Opdivo, and then she had biopsy-proven progression. We went ahead and treated her with lymphodepletion chemotherapy and the TIL product. And I was so surprised at her first CT scan that her tumor had shrunk. And by 5-6 months, she had a complete response. And I was, again, never expected this actually to work so well. Now, we do have experience in melanoma. In fact, we've treated over 50 patients with TIL at Moffitt for melanoma. And we've had patients with durable responses that have lasted for decades. But this was first time we'd really treated with lung cancer. So actually, Deborah's doing quite well to this day. She does underwater photography and she goes deep sea diving. Next slide. Another example, which is, again, kind of belies our usual expectations with lung cancer, is patients who are never smokers have responded to TIL for lung cancer. And in this case, Sherry was a never smoker. She progressed cancer progressed through Opdivo, and we went ahead and treated her with lymphodepletion chemotherapy in the TIL and the IL-2. And she also achieved a complete response. And I think what's surprising is, again, that patients can have these complete responses without being on tyrosine kinase inhibitors or things like that. Now, she subsequently had some additional tumor growth about a couple of years later, and now she's back on the Opdivo and the tyrosine kinase inhibitor and doing well again. But again, it's this concept that, there's maybe for patients like her, the Opdivo would have worked if she just had more T cells to actually do the fighting for her. Next slide. Another example of a patient, light never smoker, exon 20 mutation, who also has now been NED after getting TIL trial for a couple years now. Her name's Jan. And in her case, we actually had a little bit of a surprise where we removed her tumor and treated her with TIL. And a year later, she did have one small new metastasis, and we resected it. And the interesting thing was that the original cancer mutations that were found in her tumor were actually missing from this new tumor. So that shows that and these were the ones that were recognized by her own immune system. So that seems to show that the cancer tries to kind of evade around our immune system. But fortunately, we were able to remove this tumor, and she remains in basically NED, no evidence of disease to this day. And again, she was actually featured on the news, I think, last year. So our next plan is another trial specifically looking at oncogene-driven lung cancer, because the drug companies that are developing TIL, they aren't as actually going down this line. So I think we need to. And in this trial, patients would receive Keytruda after getting their T cells harvested, and they would, if they're responding, stay on the Keytruda. But if they're not, which ends up being the majority of patients, then we treat them with the lymphodepletion TIL and IL-2, and we quickly restage them. And our expectation is that a solid proportion of patients using a optimized TIL production method will have good responses. I'm excited to be opening this soon in the next few months, although it's unfortunately I'm not able to enroll any patients on it yet. But we do have two other trials open at Moffitt that our patients may potentially be eligible for using similar methods. Next slide. So great. And I think maybe we have the next question session.
Yeah, perfect. Thank you so much, Dr. Creelan. That was really great. And, thank you so much for your informative session. I know we received some questions before we started, and one of them really focused on what is next within the realm of immunotherapy. And I think exactly what you just spoke about is really where we need to be heading, looking at that TIL, the tumor infiltrating lymphocytes, and seeing what we could do to personalize immunotherapy for our patients. I do want to take a moment here to emphasize how important seed funding is advancing incredible work like what you've heard today from Drs. Creelan as well as Dr. Robinson. And at this moment, I'd like to just take a time to introduce you to one of our partners here at Moffitt, Carrie Beebe. Carrie,
hi, everyone.
Hi. Carrie, if you could say some words, please.
Sure. Yeah. Thanks, Dr. Gray. And thank you to Dr. Creelan and Dr. Robinson for joining us on a Thursday evening. I know they have long days at Moffitt, so we're so grateful they could join us. As Dr. Gray mentioned, I am with the Moffitt Foundation, and I have the pleasure of working very closely with the thoracic team to better understand their needs in research, as well as the opportunities that they have and projects they have in the hopper in need of funding, and then connect patients, families, and other supporters with that work. Dr. Creelan's research has historically been funded with grants, and also some of his future research that's underway is being supported with philanthropic dollars. Additionally, the project that Dr. Robinson mentioned, one of those opening up is being funded exclusively with support from prior philanthropic donations. So the support that they obtain really helps drive forward that research and accelerate the rate at which we can complete research. We're always willing to partner with you all and others who may be interested in supporting these efforts. And one of the great things about their work is that you can actually designate any gifts that you make specifically for thoracic oncology. So my contact information is on here and also in some emails you received from me. So if you have any questions or want to connect and learn more about ways you can support the department and research in this area, please let me know. Thank you all. And I will turn it back over for Q&A, which I know many of you are looking forward to. I see we already have quite a few questions. So thank you all.
Great. Thank you so much, Carrie. And, she really is our partner in the thoracic program and ensure that we receive the research dollars we need to get the clinical research off the ground and make those advances in cancer treatment. So really thank them and the philanthropy for making our research possible. All right, now, ladies and gentlemen, we invite you to continue to place your questions in the Q&A box. I will read questions and invite the faculty to answer the questions that pertain. We will address questions, and I will be sure to announce the last question for the evening prior to reading it. I do want to thank you very much so far for the questions that we've received. If we are unable to get to your question tonight, don't worry. We will follow up with you to answer your question at a later time. All right, with that, we'll get the Q&A officially kicked off. I did see some questions. I'm going to start with Dr. Creelan, if you want to turn your camera and mic on. You did get some great questions in the chat, and some may have seen them and some may not. And they really talk about the targeted and driver mutations and what you see is next on the landscape for ALK. I saw there was also some questions on EGFR, and if you could speak to those a little bit.
Yeah, so I think our first question was about Keytruda and other immunotherapies, which historically, traditionally don't work that well for patients with ALK. And it's true that at the end of the day, it's true that the TIL, we actually haven't treated any patients specifically with ALK with TIL, but for example, Richard in our video is ALK positive, and he's had a complete response with nivolumab, surprisingly. So, the truth is that we have seen patients with EGFR who also don't respond well historically to immune checkpoint inhibitors respond nicely to TIL. So it just doesn't seem to follow the same rules as immune checkpoint inhibitors. Mm-hmm. What those rules actually are still being determined. We've still only treated, maybe 16 patients or slightly more on the iAdvance trials too. But I think it's it seems to be agnostic to smoking history or oncogene driver status.
It's really great. And I think that's a really interesting point. I think that there are a lot of targeted therapies out there that are FDA approved, but all of us, I think, are challenged when they stop working for our patients and what are the next steps. And it's really exciting that you're looking at this for the patients who have those oncogene-driven tumors. So fantastic point about that distinction that we think early on that we're seeing between TIL and immune checkpoint blockade. So that is something that you should be thinking of, and we should be thinking about also. I'm going to go to, we did receive some questions ahead. I'm going to be going between the two to make sure that we get a comprehensive look at those who submitted those questions ahead of time, as well as those that are posting in the chat now. So Dr. Robinson, I had a close question for you here. For recovery from surgery, what are your recommendations for improving recovery from surgery and addressing issues such as neuropathy, scar tissue, pain?
Well, it varies greatly, obviously, on the patient themselves. I think probably the primary thing that we've found that has been shown in a number of studies is the most important thing after surgery is activity, exercise, doing things. There's been tons of studies now that have been published that the people who recover the quickest after any kind of surgery, including chest and lung surgery, are the ones who exercise. When I talk about exercise, not running a marathon, but we're talking about just walking and walking. I tell patients all the time, the way to get over the operation is 3 ways. That's to walk, walk, and walk. It helps you physically get over the operation. It helps you physically get back where you were. And mentally, it helps you get back as soon as possible back to the state that you'd like to be in that you were before the surgery. Nutrition is a very important part of that. I don't really have time to go into a lot of aspects of nutrition, but your nutrition, your intake is so important. Just to tell people, oh, go home and drink a little Boost. That's a cop out, and that's not the way to do it. It needs to be food. It needs to be balanced diet. It needs to be whole foods. A lot of the things you've heard that are good are very important to get over any type of surgery. The pain and the neuropathies and various pain that people can have, again, depend on the kind of surgery, the approach, what they had done, how big of an operation they had. And there's a number of aspects about it, and which we have to go on an individual basis when you see a patient.
Great. I think those are really, really great points. I think that we get so focused on that diagnosis and getting to surgery, but what we think it's really important that we look at that comprehensive, right, approach to the patient, including their nutritional status and their functional status. All right, Dr. Creelan, question for you here. Does the TIL therapy here, work with other mutations like KRAS 12, I think it's supposed to be G12D mutations? Patient here was taken off of Keytruda and was denied a trial. Appreciates all Moffitt is doing. If you can talk about what about those in KRAS? And I bring this, I thought this is an important question to raise to the top because we have some KRAS inhibitors that are more specific for some subtypes, and it's really moving to the forefront of research. And if you could speak to that too.
So I can't personally state that I've treated a patient with KRAS G12D for TIL, but we have treated patients with G12C or G12V, and they have had responses. G12D also has some inhibitors that are being developed by about 3 different drug companies. Mirati is one of them, MTX133, for example. So those are pills that are specifically designed to inhibit G12D. There's also some adoptive cell therapy using TCRs against G12D, which are very hard to be eligible for because you have to have the right blood type, HLA type. But the truth is that there are some options for G12D. There's also a trial we have open here at Moffitt, I think using atezolizumab plus cobimetinib.
Great. Okay. We do also have a trial that just opened this week that's looking at a pan KRAS inhibitor. So, happy to get you connected to the clinical research team where possible to get that connection for you. Along those lines, Dr. Creelan, the next question, thank you for the excellent presentation. I thought it built on your prior comments, so just wanted to tie this in. Are you finding that there are HLA types that TIL is most effective for? And will those pre-screening criteria be included in your upcoming trials?
Yeah, so there's no HLA. Obviously, HLAs are unique to every person, and their T cells are built around their HLAs. You undergo a thymic education when you're 4 to 12 years old, and the T cells that you recognize your HLA get developed. So as long as we're using a cell therapy which is autologous, meaning it comes from your own body, the cells come from your own body, then the HLA type shouldn't matter. Where the HLA type matters is when we're using a recombinant or genetically modified cell product, and that's where it becomes more of a guessing game, or you have to get tested first.
Right. I think that's a very good point, and a good distinction there between the different types of cellular therapies that are available out there and how we pre-screen and identify and match patients to the right therapy. All right, Dr. Robinson, we have a question for you here. If you have no evidence of disease for 6 years, and then you get a new cancer, can you get that cancer removed by surgery if it is caught early?
One of the reasons we follow people along with surveillance CT scans after they've had apparent curative surgery from a cancer is looking for that second primary cancer. It's estimated that someone who has a primary lung cancer and has been cured with an early stage cancer has about a 1%, maybe as much as a 1.5% chance of another cancer yearly. So it's important to follow them up. And I've seen a number of people now that have had surgery 10, 15 years ago who come back with a second primary. When someone comes back with a second primary cancer, hopefully has been usually found early, but if they've been having surveillance scans, the way cancer grows, it will show up early initially. Then we reevaluate those patients again. Is it a localized disease? Is it spread anywhere? If it's localized, can it be removed surgically? And can the person tolerate having surgery? And I've operated on many people who've taken out their second primary surgically. Fortunately, if somebody has had an operation and taken out a lobe of the lung, for example, who has limited lung function and comes back with a second primary cancer at a later time, if it's a small peripheral cancer, which is usually the case, we then have a second modality, which is very effective, and that's localized high-dose pinpoint radiation therapy called stereotactic body radiation therapy. So some of those patients who couldn't tolerate from a physiologic standpoint having surgery can still have that cancer treated and likely will be cured and go ahead and continue their life and hopefully be cured of that second one as well. So there's options available, but surgery is definitely one of those, and we do second primaries from time to time.
Great. I think those are very, very good points. And I think, Dr. Robinson, as you talked about in your presentation, that and to what you're alluding to now is that early detection and finding those lesions early, as well as those blood samples that you're talking about. There's some multiple different blood assays that are out there that are being looked at, especially one that recently was in the news with the Grail, and being able to identify cancers. I know you talked about the DetermineRx. I wonder if in that trial that we have planned, if you can talk a little bit about some of the blood assays and what your thoughts are around that also for the early detection and risk stratification. And that is a little bit of a spinoff from one of the questions on here.
Now, biomarker studies have been everyone's tried to find something that's a biomarker for some cancer, either to find the cancer early or to figure out where it's going to go. The classic biomarker that everyone, at least half of the population knows about, all the males know about PSA, which is the prostate antigen that we all most of the time get blood tests for, and it tends to go up if you have prostate cancer, and is a very good biomarker for prostate cancer and a biomarker for follow-up after you've had prostate cancer and have been treated. So that's the classic biomarker. We've been trying to find biomarkers for a number of other different kinds of cancers, both for early detection and otherwise. Unfortunately, there's been so many that have come out. Many clinicians have been sort of jaded because they've seen initially exciting results, and then when they've been done in larger studies, then they turn out not to work as well. The Pathfinder study just came out just recently was a study of 6,600 participants where they did this Grail, did the Lary study, a blood test, looking to see what they could find in terms of cancers. And what they found was, of those, they found 65 of those, in other words, of those 6,600 patients were positive, of which those 29% were actually true positive. Those were found to cancer. However, 39 or 36% of those patients, 36 of those patients had false positives. So they went through a lot of both anguish and a number of different tests, and the false positives were greater than the true positives. And the problem is also a lot of those that came back that were positive were actually lymphoid. They were lymphoid tumors. So it's not really certain how important that is. Nonetheless, it's an exciting trial, and of the biomarkers that are out there looking at various kinds of cancers. They're currently doing a trial in England of 165,000 people And it's the large studies that give us a better idea whether it's actually a practical test. So there's others out there. There's one called Detect that's out there, a number of different ones. So it's getting exciting, the possibility that we may have some blood test that you can go to your doctor and get tested for and see whether you have a high risk or not. But right now, it's not sort of ready for prime time.
Yeah, so I think those are great. And I think these are all reasons why we need to study them, these different platforms in one study, and see which one really is the best one and which one we should implement for our patients here. I think those false positives that you mentioned, can be very disheartening and put patients down a path of further workup when they didn't need it.
I can tell you about myself. There's a Cologuard is a test, is a biomarker test.
Yeah.
Cologuard is a biomarker test. Supposedly, you're not supposed to have a cancer. You won't have to worry about having a colonoscopy. So you get a little stool sample, they do a Cologuard test. Well, they didn't tell you there's a fair number of false positives. I was one of those people who had a false positive. So I sat waiting another month before I get a colonoscopy, worried that I had colon cancer. I was trying to figure out who was going to do my colon surgery. I was really quite distraught for a month. Colonoscopy, clean as a whistle. There was nothing there. It was one of those false positives. So false positives are very distressing, and I know that myself personally.
So we really have to be very careful about these assays, especially the ones that come out, and just make sure that we vet them also. I do see a couple of trends on the chat here about clinical trials and how do I find out about treatment options for myself and finding out what our trial portfolios are. I'm going to ask Carrie and Stacy and the team to get the information to those who are registered, but we do have a website. We also have a clinical trial navigator who can really look at your case and help you and help us, the providers, to match you to the right trial. So really fantastic questions that are coming through, and we will be sure to get you that information so you can get linked with that. Dr. Creelan, there are some questions about mesothelioma on here. While we're not focusing the discussion, I think maybe some talk about where we are going with mesothelioma and what the options are that you see. I do also want to mention that one of the trials that we just opened is specifically directed at mesothelioma and answering key questions there. Dr. Creelan?
Yeah, so we have actually a variety of approaches for mesothelioma at Moffitt. We have surgery, we have radiation, and we have systemic therapy, which is really the mainstay of our treatment for mesothelioma. And one of the biggest breakthroughs in the last year has been immune checkpoint inhibitors being available across the country for patients, Yervoy and Opdivo. But if you look at the numbers, a lot of the time the patients still, this isn't enough. So we have a clinical trial where we give intra-arterial chemotherapy for mesothelioma. That's run by Bella Kiss in our interventional radiology suite. We have a clinical trial where we do combined modality therapy. We do chemotherapy, radiation, and surgery for mesothelioma. And indeed, I think we have some other promising trial approaches as well. I think the key problem, of course, is that mesothelioma tends to get diagnosed so late. It tends to sneak under our radar a lot of the time. And in fact, I'm looking forward to this being detected also maybe on screening CT scans sometimes.
Those are great, very good points. And, I think the key thing there is making sure that we continuously challenge the standard of care, challenge the norm, and make sure that we are doing everything we can to think about what's going to be the best and most individualized therapy for our patients. All right. And so, Dr. Creelan, then the other question here, and I don't think we've touched on this, is that we know that patients with MET exon 14, particularly those at stage 4, have some new drugs coming down the pipe. What else is going on within this space? And I know you personally are leading one of our trials for MET, and if you want to talk about that.
Yeah, so for MET exon 14, I actually haven't seen that question. Oh, I see.
Oh, it just came up. I'm sorry, I probably didn't give you enough time.
Yeah, I see it. Okay. So one of the newest mutations out there is this MET exon 14 skipping mutation. And we have a couple different ways of attacking it. We can either use a small molecule inhibitor that basically blocks the machinery of the MET kinase, and so it kind of shuts down the cancer cell. Then we also have antibodies which bind to the MET that's expressed by the cancer cell and kind of kills off most of the MET cells that way. So there's, I think, 3 clinical trials we have open. It's kind of hard to go through all of them at once. I don't want to overload you with information, but both of those approaches are being used in those trials. Patients who are naive, who've never had a MET inhibitor before, they would probably be eligible for one of those trials, and patients who've only had one prior MET therapy also would probably be eligible for one of those trials. I think I missed that question. So
no, I think that's a great summary. I think the key thing there again is thinking about what's next, and challenging that norm and not accepting the status quo for our patients. Dr. Robinson, we have a question that I'm going to send to your way. In a person with an active lifestyle and good lung capacity, how much lung can be removed with minimal impact?
Well, it's actually quite remarkable. The good Lord saw fit to give us a lot of extra lungs, so we can get rid of a lot of it and still, unless you really abused yourself for a long time for your lungs, you can get away with an awful lot of lung removed and still have a very active lifestyle. I've done a number of people taking out the entire lung on patients and have them go back to doing active. In fact, I've had 2 of them gone back to doing scuba diving. In fact, one gal went out and did free diving. Now that's really nuts. That's where you hold your breath and you hold on to a heavy rock and you go down 100 or 120 feet or so, free diving. Nice lady, must have been nuts, but she could sure do it and didn't have any problems. And I took out one of her lungs, her right lung, and she did it without any problems. So you can remove a lot of lung. Usually we talk about a pneumonectomy is probably taking out an entire lung is probably the maximum we usually do. Although we'll have patients who will take out a lobectomy on one side and a lobectomy on the other side. So it depends on the baseline lung function that people have.
So I think that the key thing there is that good lung capacity and that active lifestyle, it sounds like. And then Dr. Robinson, big question for you here. Are we close to a cure for lung cancer? What's your thoughts?
Well, I wish I could say yes. I think we're getting better. Like most cancers, it's incremental. No one's going to run out of the lab. Eureka, I found the cure to cancer. Even Dr. Creelan's not going to be able to do that. On the other hand, we've made a lot of progress. Now we're currently up to, which doesn't sound great, but we're up to 21% of the people who have lung cancer are cured long-term. When I first started in this many years ago, it was about 8 or 9%. So we're up to 21%. And that sounds like that's not a great number, but there's so many people who have lung cancer. You're talking about thousands of people that you've taken away from, essentially sort of taken out of the jaws of death, and they're going to live a normal life. So it's improving. The advent of immunotherapy and so many of the therapies that Dr. Creelan's talked about are extremely important and have really taken a lot of people who didn't have a very good outlook and allowed them to live a relatively normal life, if not a completely normal life. We're trying to find those early stage patients a lot earlier. That's why the importance of the screening, the surveillance, all of the things that we're talking about, trying to get patients away from later stage disease. There was a study that just came out, which is kind of interesting, is that there's less patients now presenting with late stage disease and then more patients presenting with early stage disease. Now, it's not that we have less cancer. I think we've had a shift in stages. We're starting to find people earlier. So there's been a stage shift. That's the classic term we use in the jargon. And there's been a stage shift to more people in early stage disease, likely because we're doing a better job of finding those. But there's a long way to go. If only 4% of the patients who are eligible to get lung CT screening are getting them done, there's an awful lot of people out there that could be helped if they just came in earlier.
Yeah, I think those are all great points. And I think you summarized everything very well with exactly what we are trying to do. And I do see that last question. I'll just say it out loud. Why is lung cancer research not funded at the level as breast cancer when more people die from lung cancer? You know, we are doing everything we can to advocate at the DC level, the local, regional, and national level to get more funds toward lung cancer research. I agree with Dr. Robinson. You know, one of the key things that we also need to dedicate research funding and attention to is lung cancer screening, as well as these innovative approaches such as the TIL therapies. All of these together are going to move the needle forward and move us closer and closer to that cure. Well, I want to thank everybody, thank our speakers, thank our experts for taking the time. Thank you very much for joining us as well. I think that'll do it. We hope you found this webinar informative, and we appreciate your continued support as we work to revolutionize cancer care and provide the best possible outcomes for our patients. Have a good evening.